we have issues with are not adequately trained on IPC, and we've got absent structures and materials. Now, during the last outbreak, there were some things that were discovered that fueled the outbreak, and I'm looking at this in the context of IPC. One, there was distrust of hospitals or centers. Most people had poor health-seeking behavior. They preferred self-medication, or they call a nurse to give them a drip at home, or they go to the traditional medicine healers. And even the healthcare workers were unfamiliar with that disease. And so some people were sent away from the healthcare facilities, and they perpetuated the disease. I'm going to show us just a few pictures, to kind of drive home this point I've mentioned. This picture was an inappropriate use of PPE during the Ebola outbreak. Unfortunately, it was when the Chinese came, and they were not just using this in either suspect wards or whatever. They were using it routinely in every clinic. We talk about PPEs, but sometimes people forget to wear PPEs. Now, we had issues, and these pictures are really driving home the point why we had such a large outbreak, because, there were places where we had, some measures were taken to try and control the outbreak, but the IPC component was not considered when taking these measures. So suspect patients were put in classrooms, to take them away from the population, but there were no IPC measures in place. And so they waited in these places. The place was being contaminated on a daily basis. There were no plans for decontamination or cleaning up those places. And even when people died, they were kept there for days before being picked up because it took some time. And so that kept perpetuating the outbreak. And then we had vulnerable children, orphans whose parents had died and they had survived. And they kept living in those contaminated environments. So in Africa, what's our way forward? Despite all the advances we have in lab medicine and other aspects of medical science, the basic means of addressing infectious diseases remain the same: public health education, infection prevention and control, surveillance, and preparedness. So for we resource-poor countries, as we're called, if we don't address these things, it's going to be a further depletion of the resources. There are economic implications. There's increased devastation to our nations and depletion of our health workforce. And we get a vicious cycle. But the truth is, IPC is the only sustainable way out in the control of transmissible disease and mitigation of future outbreaks. So at our healthcare facilities, we need policies, we need trainings, we need appropriate use of PPEs, and we need to get into the habit of triaging at every point in time. At the community level, we need to educate our people. So awareness, knowledge, hand hygiene, safe care of the sick. And I am ending with this slide, standard precautions. It's a reminder to us all that every body fluid should be treated as though it is potentially infectious. This was something that happened during the EVD outbreak, and I felt it was ingenious because it would not work only for Ebola, it will work for a lot of the diarrheal diseases that we have. So the lady roasting her corn said, "Don't touch the corn, point to the one you like so you don't spread Ebola." Thank you.
Thank you very much for that lucid presentation. Our next presenter is Professor Ashile Abimiku. Abimiku. Professor Abimiku is the Executive Director of the Institute of Human Virology here in Nigeria. And the newly formed International Research Center of Excellence. Professor Abimiku is a professor at the Institute of Human Virology, University of Maryland, School of Medicine, in Baltimore in the United States and has over 2 decades of establishing laboratory infrastructure and science in Nigeria with long-term collaborations with the United States of America. Her research focus is on the role of HIV subtypes in disease pathogenesis using the mother-to-child model and effects of co-infections such as tuberculosis on HIV pathogenesis. Her funding grant allows Nigeria to epidemiologically characterize different cohorts and build capacity of government officials and Nigerian researchers in preparation for the future conduct of HIV vaccine clinical trials. Professor Abimeku also joined the effort by scientists in Africa in the field of genomic science through the establishment of biorepository of the international standard to support investigators in West Africa under the National Institute of Health and Wellcome Trust funded History Africa initiative. She has trained many cadres of Nigerian students and is internationally recognized for her leadership role in HIV research. Professor Abimeku is a member of the World Health Organization Vaccine Advisory Committee and a board chair of the African Society of Laboratory Medicine. Please join me to welcome a distinguished Professor Abimeku.
Thank you, Mr. Chair. Good morning, colleagues. Today I will not be talking about the work that I've done and the research activities that's going on here in Nigeria that is relevant to this conference and summit. What I will do is wear the hat of the African Society for Laboratory Medicine and share with you what that organization is able to do to contribute to the global health security agenda. And just in case I run out of time and I don't get to all of my slides, up front, I would like to recognize the input by Sarah Keita, who is the director for the African Society for Laboratory Medicine Global Health Security Agenda. So to start my first slide, and I really want to thank the previous speaker because she's really made my presentation much easier in the sense that she's given us the significant input in terms of the background information that would help understand the activities that the African Society for Laboratory Medicine are involved in terms of contributing to global security. So my first slide is a complicated slide, but it does make sense. So what it tries to summarize is that to address the Global Health Security Program agenda, one has to address a number of very important parameters. Those slides don't transmit really well over here, so I will be turning back and forth. So one of you just heard from the previous speaker of the importance of expanding and strengthening the laboratory network. So this is absolutely critical because the infections are not focused in an area. It is a global security problem. So it's also important that in our response to these epidemics, that we respond in terms of networks and build on our strengths as well. We need to be able to map and track the infection, to be able to provide the necessary interventions and interruptions of the infections. To be able to do that, we have to be cognizant of the whole system, It's not based on just one parameter or the other in the health system. So the FELTIP program, it's very appropriate in that type of setting, because what it's brought together is multidisciplinary young African scientists that can really build a whole system. So you need really good clinicians, you need epidemiologists, you need laboratory personnel, you need pharmacists, nurses. I mean, the whole healthcare system really needs to be built to address this. And the community as well. In a number of these epidemics, it really starts with the community. So your community has to be empowered in terms of knowledge and just simple steps that they can take to disrupt the infection, just like the lady with the corn was doing in the previous presentation. And then we have to ensure sustainability. And I'm sorry, that maybe the government officials are here today, but certainly not as many as there were yesterday. And that's a shame, really, because they have an incredible role to play in terms of sustaining this, the capacity that is being built and the preparedness of a nation. It is good to have partners that partner with us. The U.S. government has been recognized incredibly throughout the meeting, and WHO and the other global organizations. But it's very important for a nation to also be building structures that will stand the test of time and that will stand the different streams and uncertainties that comes with funding, and depending on who is governing or determining the funding, whether it's Democrats or Republicans. So this really is important for every single nation, that for sustainability, they work on that. So what are the core principles? So it does address inclusiveness. It does address connectivity, collaboration, advocacy, ownership, coordination, all of the issues that I've brought up. And then just to point out, for ASLM, important partners are those that have participated in this summit so far. So like I told you, this is probably the most important slide, and I've already been given indication that I should be finishing up soon. So I apologize for the rapidity within which the other slides are going to come at you, but really, quite frankly, this is my talk, or this is the talk for ASLM. So what has ASLM done? One of the things that it has done is to bring together a consultation for how can we strengthen the laboratory in Africa. And this was done in Freetown. It involved a number of important stake players. There was a discussion of how will the public health laboratories play a role in surveillance, in regulation of diagnostics that you're going to use to be able to track this epidemics. Just to point out that there is a significant role, like I say, for country leadership led by the Ministry of Health. And there has already been a Freetown declaration that all of you should be very familiar on, but it really emphasizes all the things that I've shared with you in terms of countries' readiness and the use of laboratory networks to address this. So far, the Maputo 2.2 declaration creates a framework that uses the tier system that is that makes more sense in a lot of African countries. So it does recognize the role, the leadership role of the Ministry of Health, but also very closely to that is your national health, public health laboratories that are at your very advanced level. And then, of course, the roles that the regional and the district and community-based surveillance and health clinics play in terms of establishing connectivity between these different health systems. One of the things that ASLM has been involved in doing is establishing what we call a scorecard. And this is really to help different countries to know where they are. So a number of you might be familiar with the accreditation system in laboratories that determines the quality of any work that comes out of the laboratory. This is very similar. In terms of addressing epidemics, where are you in terms of your laboratory network? Are you at a position that you can deal with pathogen that require class 4 kind of biosafety level, or are you at the level that you're just dealing with a biosafety cabinet in an open area? So this helps a country to map its laboratory network and its readiness, and and to identify the kind of infrastructure they would need to address any epidemic. So that has been very important. And what ASLM has done in the last 2 years is to test this in 17 countries in terms of readiness. And these countries are shown out here. Not surprising, a number of them are in West Africa, where the epidemic, the outbreaks with Ebola has really made an impact. Now, this just shows what ASLM has done with these 17 countries. It really hits on all the issues that I've covered already, the laboratory network, capacity and services in terms of building the whole system, specimen referral network in a very safe and contained manner, involvement of the community, and the rest of it. So this just gives you an idea of how varied the activities in these different countries could be. One of the key activities is, how safe is your biosafety cabinet as you operate under it with quote-unquote infectious material? How often do people certify their biosafety cabinet and make sure that the worker is protected against it? So that has been done in a number of countries where the biosafety major labs that participate in surveillance have their biosafety cabinet certified on a regular basis. And along with that is training Nigerian biotech engineers to be able to do this for the various countries as well, and more importantly, mapping. What has ASLM learned so far? It has learned that it's absolutely critical that before any intervention that there is a significant engagement of the country's leadership. And the country leadership is just not only Ministry of Health, it's Ministry of Health, the government officials, the health workers, as well as the different partners that are operating within the country. And that under the leadership of the Ministry of Health, it should be possible for all the partners to collaborate so that there is there's synergy between everybody. There is a buy-in, so it's a program that everybody has agreed on, and we are all moving forward together to solve the problems. And there are forums to bring multiple funders. Sometimes it's really not the country that's the problem. It's the number of multiple funding that's coming that is not coordinated within the country. So it's important to do that as well and involve NGOs, be very inclusive, that have the capacity to help and gain trust, basically move as one group. So my last 2 slides, it's really to invite all of you to ASLM biannual conference that happens every 2 years. This takes place, the 2016 takes place in Cape Town. All of you are members of the African Society for Laboratory Medicine, and hope that you will participate in that. We have very competent co-chairs. One is Professor Emerabe from here in Nigeria, and the second is Professor Wendy Stevens from Cape Town. So we hope to see you from the 3rd to the 8th of December 2016 in Cape Town. Thank you.
Thank you very much, Prof, for that beautiful presentation. The third presentation is going to be on antimicrobial resistance. How do we effectively prepare for the next pandemic? And this talk will be given by Professor Abdulrazak Habib. Professor Habib is an infectious and tropical disease physician, public health implementer, epidemiologist, educator, and a professor since 2009. He trained and worked at the university hospitals in Nigeria, Saudi Arabia, England, and Singapore. He has interest in global health, including community-acquired infections, emerging infections, antimicrobial resistance, Ebola, SARS, HIV infections, immunology, clinical epidemiology, tropical diseases, and health economics. He participated in the initial characterization of the emerging infection, COVID-SARS, in Singapore. He served as Director, Medical Services from 2005 to 2007 at the Institute of Human Virology, Nigeria, which is an affiliate of the University of Maryland, USA, where they implemented care to over 1/3 of HIV-infected patients in Nigeria. He serves on several boards and committees, including the National Drug Surveillance Advisory Committee, National Expert Committee on Adverse Effects Following Immunizations, National Immunization Technical Advisory Board, Group Nigeria, the Epidemic Preparedness and Rapids Committee, National Committee on Multi-Drug Resistant Tuberculosis, and National Task Force on Control of Snake Bite. Professor Habib is an international advisor to the Royal College of Physicians in London, member, Board of Directors of the University of Melbourne-based Global Snake Bite Initiative, and member, West African Academic Alliance of the Accordion Foundation, West African Infectious Disease Institute. He addressed the 69th World Health Assembly, WHO Geneva, Switzerland, in 2016. Join me in welcoming Professor Habib to the podium. Thank you very much.
Thank you. Thank you, Mr. Chairman. Good morning, friends, colleagues, and senior colleagues. I'll be presenting on antimicrobial resistance. How do we effectively prepare for the next pandemic? In this slide, an old slide presented by Anthony Fauci on global health security at the turn of the century, he identified, among other things, vancomycin-resistant Staphylococcus aureus in the United States and in Japan, multi-drug-resistant tuberculosis, drug-resistant malaria, multi-drug-resistant typhoid fever in sub-Saharan Africa as major problems that will confront humanity in the century. Here, it's a slide that is just showing the impact of initial ineffective therapy as regards mortality from community-acquired pneumonia. And you'll see that it multiplies about 5-fold higher mortality resulting from initial ineffective therapy. Unfortunately, you may not see this closely, but clearly, but the impact of resistance is multifold. You could see lengths of hospital stay or lengths of infection tends to be a lot higher in those who are infected with resistant organisms. Mortality tends to be higher, and also the cost of care tends to be higher. In this old slide, it's shown that in the United States, over $400 billion are spent due to bacterial resistance in around 2005. Similarly, getting into the sub-Saharan African context, you'll see that following the initial discovery of penicillin-resistant pneumococci in South Africa and Spain, subsequently it's disseminated throughout the continent. In various parts of the continent, you could see Nigeria in an old slide showing about 36%. You could see in Algeria 5.7%. In East Africa, values of about 0 to 1.8% initially. These figures have since worsened. These are also seen in Abidjan, in Côte d'Ivoire. Unfortunately, you may not see it very clearly. And in Senegal, Dakar, showing only about 15% of pneumococci are actually susceptible pneumococci. And similarly, you could see in Kenya, in Uganda, the same sort of picture is repeated. And in any country in sub-Saharan Africa, if you look at any major city or any hospital, you'll find the issue of pneumococcal resistance has been highlighted, has been documented clearly. This is just an example from Nigeria, from major cities in this country. You could see in Benin City, about 32.4 not susceptible, Ibadan, Ilorin, Maiduguri, Sokoto, Kano. And if you look at any other country and some of the major conurbations there, the same sort of picture is noted. And clearly there is a very good relationship between outcomes in managing serious bacterial infections that are resistant. In this case, we have vanco treatment failures as the MICs for vancomycin are rising. The rate of failure also tends to rise. You may not see this. This is in 4 South African cities. This is not my slide, this guy, Richard's slide. He showed in Johannesburg with Acinetobacter the resistance to several classes of antimicrobial agents. In Pietermaritzburg, in Cape Town, in Durban, the same sort of picture is repeated. So clearly, gram-negative drug resistance is a major problem. Again, using more stringent measures. If you look at, say, in Kano, we've shown that resistance to pneumococci, to Staphylococcus aureus is a major problem, and also to Enterobacteriaceae. And lately, we've been seeing carbapenems-resistant Enterobacteriaceae in isolated pockets in Kano, in Zaria, I'm told, and we've seen also importation of these bacteria from other parts of the world, mostly in the context of medical tourism. Multi-drug resistant Salmonella typhi. Recently, Gordon Daugen from Cambridge showed a particular strain, H58, has been transmitted from Asia to East Africa, and it seems to be displacing the drug-susceptible Salmonella typhi in this continent, and he thinks in the coming years it's going to be a major problem. Tuberculosis also is a major problem. In this slide, you could see multi-drug resistant tuberculosis accounting for about 60,000 in sub-Saharan Africa, and in this country, several reports, including ours, shows it's a major issue. And we're all aware of the extensively drug-resistant tuberculosis that emerged some time back in KwaZulu-Natal, leading to death of about 52 out of 54 people infected with the bacteria. HIV drug resistance, you could see that West Africa tends to have has the highest in this recently published paper, with 82 to NNRTI resistance and to tenofovir. while the East Africa, they tended to have lower values. So Southern Africa and West Africa, compared to other regions of the world, have the highest drug resistance where HIV medications are concerned. Similarly, we do know the story of chloroquine resistance, and lately the emergence of artemisinin resistance in East Asia, in Cambodia, and subsequently in Vietnam. Recently, Brian Greenwood looked at sub-Saharan Africa, in particular looking at the Kelch-13, the polymorphism, which appears for now to be absent in sub-Saharan Africa, but clearly this is also a worrisome development should it come to Africa. The issue of use of antimicrobials as drivers, as propellers of drug resistance, its use in animal husbandry has been noted, and there is considerable politics and commercial interest is something that has to be looked at closely. And somehow drug development has not kept pace to the antibiotic resistance. There are fewer drugs in the pipeline. So by way of what we could do, things like surveillance, as mentioned by previous speakers, antimicrobial stewardship, and this is a GSK surveillance program which is put temporally, longitudinally, showing that clearly there is increasing worsening. The rational antibiotic use, other steps like vaccination, especially for bacteria like, say, pneumococcus, clearly needed to be expanded, using more rational drugs, things like monotherapy where it can be done rather than combination therapy. And recently there is a draft document on the WHO website to curtail HIV drug resistance with the following component agent. I think they are still taking corrections and suggestions until 16 September, things like developing and implementing HIV drug resistance surveillance, quality, expanding laboratory capacity, incorporating multi-sectoral approaches. There are plans to curtail these things. So what we can do, Professor Lainka has already mentioned, strengthening infection control, revamping laboratory capacity for case detection, both classic and molecular epidemiologic surveillance, rational use of anti-infectives, use of evidence-proven case management strategies, among other things. We need to also strengthen antimicrobial agent regulatory oversight at facility and national level, regulated use in agriculture, pursuing a one world, one health approach, expanding immunization access against bacterial infections, clearly sustaining funding, among other things. And there is need for national and international mechanisms and laws that may be needed to have a healthier Africa. So in conclusion, somehow, if I recall the last major pandemic the world has encountered, i.e. the great influenza pandemic leading to at least 20 million deaths in 1916, 1917, I think the issue of antimicrobial resistance could well surpass that if nothing is done. And so there is really the need for a concerted efforts at all levels to contain it. And I would like to think William Osler's statement that humanity has but three great enemies: fever, famine, and wars. And of them all, fever by far is the greatest and is the most terrible. And clearly antimicrobial resistance has to be contained if we are not to have infections and that are related to superbugs in the future. I conclude by acknowledging colleagues from my unit, Nasha Baru, Ilyasu, and Hamza, and also the NFLT program. Thank you for your attention. Thank you.
Thank you very much, Professor Habib. The presenters have had their time. It's our time now. I think we have about 12, 13 minutes for discussion. You've had the presentations from Professor Lainka on infection prevention and control, and Professor Abimiku on the African Society of Laboratory Medicine Global Health Security Agenda Program, and lastly, but not the least, Professor Abdulrazak Habib on antimicrobial resistance. You will, as I say, we have slightly over 10 minutes for discussion, so you indicate by raising your hand, you will be recognized, and you'll come over to the mic here, maybe make a small queue, and then identify yourself as usual, and specifically indicate the presenter to whom you're addressing your comment or your question. Thank you. Yes, over there you can come. I will take maybe four. Peter will be the second. Professor Kolocha. Third. Any other for now? Okay, please come over to the mic and ask your question.
All right, thank you very much for very great presentations we've had. I like to say, Biodun is still the name, Nigeria Fellowship. I want to find out from the last speaker, consequent upon the findings from previous summits on the antimicrobial stewardship issue, whether we have, for now, national studies on burden of antimicrobial resistance in the country. We've had some subnational studies, but at least for the country, for instance, what is really the burden, maybe for instance, say for MRSA. And also I want to find out from the presentation on lab effort, I think from Prof. Abimiko, the standardization effort towards the use of antibiotic susceptibility testing guidelines within the countries. I found out, for instance, the CLSI guideline, before we can be comfortable to say that this is the results that we are getting and it's reliable, I think it is necessary to know that the right guidelines are being adopted in those settings where the results are being generated. So I just want to find out the effort of the ASLM, for instance, at country level, in all our laboratories, adherence to these guidelines to authenticate the results we are getting from them. Thank you so much for your attention.
Thank you so much for the presentation. Peter Nsubuga is still my name. And I'd like to ask Professor Lainka and Professor Lashley to comment on how we can institutionalize IPC training in pre-service, in-service programs so that we can mitigate the terrible deaths of health workers in these outbreaks of all types, or the infections that health workers always get as they struggle to protect the community. I think we are missing a piece on how to protect health workers themselves and make it a little bit more predictable other than ad hoc. Thank you.
Thank you, Mr. Chairman, for giving me this opportunity. I really congratulate the presenters for their talks. Starting with Professor Abdulrazak. I don't know, can you please briefly explain to us the possible role of probiotics in antibiotic resistance? And since we talk about strength, because all that you presented, the three of you, had to do with the strengthening of the health systems. The information network is also very important. And I don't know, maybe the three of you can address it in one word or the other. I appeared not to have alluded to that much in the presentations. And the very last thing I want to say is that when you talk about strengthening health systems in Africa or the region as a whole, the very most important thing that has happened to Nigeria, and by extension to Africa, is the establishment of this FELTI program. and the unique character of the fellowship program in Nigeria. I think there's need for a small ovation on that. I mean, you give some small ovation for Nigerian fellowship, because the reason why I'm saying that is the tripod on which this fellowship exists is so much. I wonder why it has not been mentioned now and over again here, that the character of the Nigerian fellowship is what should be exported to as many countries in Africa as possible. Because the origin of the fellowship here is because of the avian
10 years has gone, people are still doing syndromic management of STIs. Also in places where there is malaria and bacterial infections, you find that people do not have the capacity to rule out bacterial infection, and they would just start antibiotics based on symptoms like fever and the severity of the illness. In that context, how do we make sure that we're not protecting bacterial resistance? Then you talked a bit about HIV resistance. I wanted also your comments on the possibility of promoting resistance in the view of the latest WHO